All right, guys, it's 9:40. We'll get started. So, good morning and welcome to Friday Chalk Talk. And today we're lucky to have a special guest speaker with us today. We've got Dr. Andy Esch, who's the Vice President of Education at CAPC. Welcome, Andy.
Thanks for having me.
Yeah. Today's format is really going to be two parts. So first, Dr. Esch is going to start with a presentation on the topic at hand, which is palliative care's relationship with chronic pain. And the second half will be an open discussion. So with that, thank you guys all for being here. And Andy, I will hand it off to you, sir.
Thanks, Martin. I appreciate you all having me here and joining. When I was first asked to do this talk, the subject of opioids came up as something that, would be provocative and interesting to talk about. And I wasn't sure which way to go with this. But what I thought we could do this morning is, rather than some, big scientific talk on, opioid pharmacology and things like that, we would look at it more from an operational or sort of program directed standpoint. And with that in mind, I wanted to think about our role as palliative care clinicians, the patient populations we treat and that are appropriate for us to treat, and how do we accomplish the goal as a field of making sure that high quality palliative care is available to everyone and everywhere. So with that, I want to start just with a couple questions, and not necessarily looking for answers right now, but I want these kind of in the back of your head as we go through the next 20 or so slides and enter into the discussion, because I've presented on this topic a few times, and it's a pretty polarizing topic as to whether palliative care should be treating chronic pain. And under what circumstances would a palliative care program consider a chronic pain patient appropriate for palliative care? So just think to yourselves what your answers to those two questions might be, or what other follow-up questions you might have as we kind of work through the next 20 slides or so. So there is an intersection of chronic pain, serious illness, and palliative care. They don't all exist in their own silos. And so as palliative care providers, if we're true to our mission of making sure that high quality palliative care is available for everyone and everywhere, I think we need to take this intersection and spend a little time with it. So just to start off, a couple definitions. So serious illness, we know it when we see it, but basically it's a health condition that carries a high risk of mortality and either negatively impacts a person's function or quality of life or strains the caregiver. And most times we know it's both. And chronic pain is interesting because there's no great consensus definition, but pain that lasts for at least 3 to 6 months beyond the period of expected tissue healing, or pain that occurs at least half the days within a 6 month period of time. So just keeping those definitions in the back of our mind too as we go forward. Chronic pain is common. There's some studies that have shown us that 25% or more of older adults report persistent, moderate to severe pain for 2 years or more. This is pain that limits their life or work, or just impairs their functional abilities. It's associated with depression, anxiety, substance use, and reduced quality of life. And we know that, when we see a patient with cancer and they say, "Oh, I have pain," that makes sense, right? Cancer hurts. But we have enough studies now to show us that other serious illnesses are affiliated, linked with chronic pain as well. And a high percentage of these patients with things that we may not consider painful, COPD, dementia, CHF, also have a lot of chronic pain. Maybe it's arthritis, maybe it's related to, tissue swelling. We don't know exactly in a lot of the cases, but we know that this chronic pain persists for periods of time that are far outside the hospice benefit. So with that little bit of background on chronic pain and who has it, do those patients look and sound like palliative care patients to you? And again, just to think about as we prep for the Q&A or the discussion part after it. And what are the downstream consequences of people that have undertreated or untreated chronic pain? Well, chronic pain we know is associated with functional impairment, reduced quality of life, depression, anxiety, and substance use or opioid use disorder. So this is a pretty profound impact that it has on people's lives. And I highlighted functional impairment and reduced quality of life in blue. I probably could have highlighted depression and anxiety as well, because I ask another question. Do these look and sound like things that we address in palliative care and that are within our skill set? Again, just to think about for the discussion. But there's challenges. And this is where, when I've spoken on this before, this is where a lot of the resistance comes from. Do we have adequate training on how to treat chronic pain? Do we know the CDC guidelines? Have we read that enormous document? We don't want to cause harm. So if we're not trained in it or we're not comfortable in it, we worry that we may cause harm by dabbling in it. Not having the time or the resources to provide this type of therapy. I don't want to make any assumptions, but if you guys on this call have all the resources and time that you need to perform your day-to-day functions as palliative care providers, you'd be the first program that I've ever spoken to that does. So we're all pressed, we're all resource starved. So adding one more thing to our mix is intimidating and seems overwhelming. A lot of the non-pharmacologic pain treatments aren't covered for patients, or if they're covered, the criteria for getting them paid for is so narrow that it doesn't apply to all the patients. So it really limits what we can do from a non-pharmacologic standpoint for getting patients PT, OT, cognitive behavioral therapy, the things that may help them with their chronic pain. And we all worry about overprescribing. So I'm going to make a case here that we can do these things, that it's not too intimidating, and that we do have the skill set to do this. So I'm going to apply what we do and how we approach our care of patients from a palliative care perspective, and see what that looks like if we take that template and put it into chronic pain. So people that get chronic pain also get serious illness. So we can't avoid this patient population. I can make that argument for people that have opioid use disorder too. They will eventually have a serious life-limiting illness and be technically palliative care patients. So I do think that if we're true to our training, if we're true to our field, and we want to provide high quality palliative care for those who need it, wherever they reside, then I think we need to be thinking about what do we do when those chronic pain patients and OUD patients develop those illnesses that put them in the realm of palliative care. And there's a blueprint for this, and it revolves around assessment, building relationships, knowing and using non-opioid therapies, knowing what to do if non-opioid therapies are ineffective. This is where opioid therapy comes in. Be comfortable with deprescribing. And I think one of the most important things on this slide, and we'll go a little bit more in depth on each of these, but have a plan for what happens. I think most of us go along and we know how to assess. Relationship building is what we do. We're in palliative care because we communicate and we listen. So those are the keys to relationship building. We are good at pain and symptom management. So non-opioid therapies and opioid therapies, I think we're comfortable with. But deprescribing and having a plan are the things that really sort of make us nervous. What do we do when we find somebody who's misusing opioids? Do we know what to do, and do we have a plan? And if you don't, that's a very scary place to be. So let's just talk real quickly about assessment. This is what you do when you see a new patient. You review records, comprehensive H&P, ask a pain history, do a functional assessment, find out what they've been on, what's worked, what hasn't worked, do some screening for mental health and substance use histories, ask about sleep. And the one note I'll make here is, with diagnostic testing, resist the urge unless you really have a high suspicion for something, because in my experience, there's a lot of incidental findings that come up when you start putting people through CAT scanners or MRIs. And it ends up just causing a lot of anxiety and cost where you're chasing around something that, you know, may or may not be the cause of the chronic pain. And, you know, it can cause a lot of barriers to the next section that we're going to talk about, which is that relationship. So my advice is, if you're going to do the test, be very clear what you're doing it for, and then be very clear about how you explain the findings to the patient in plain language that they understand. Other thing I'll say about assessment is use your team. In palliative care, most of us have teams. I know that's getting more challenging in the days of productivity and RVUs, but most of us do have teams that incorporate social work, and if we're lucky, spiritual care. So utilizing social work, nursing, spiritual care, this is ideal and will help you set up to identify all the things that are contributing to somebody's chronic pain, because the physical doesn't just happen in a vacuum. You know, the emotional, the angst that goes along with being in pain, you know, the spiritual questions of why this has happened to me or why is this happening to me, all those apply here and contribute to the overall experience for the patient. So that's part of your assessment. Do a full exam, resist the urge to start throwing people through scanners, and use your team. Next part is build relationships. Patients with chronic pain are frustrated, depressed, or exhausted. I would even argue that patients with chronic pain, and absolutely those with opioid use disorder, are suffering, and those things are causes of suffering. So if we're true to our field about managing suffering, we need to be thinking about, what do we do with chronic pain and OUD when people are in our clinic and they have serious illness and they have these other things going on. So to do this, you need to build trust and collaboration. Think about what somebody with chronic pain has experienced in the last 10 years as we've become aware of the opioid epidemic. Everywhere they go, they're treated with skepticism, disrespect. It's a tough place to be. It's a place where they're suffering both emotionally and physically. So we need to address our own unconscious biases towards pain patients. That may be race. That may just be what we think of people who are on opioids long term. You know, words like addiction and things that are fallen out of favor, and using non-stigmatizing language, that's all pretty new. So some of us may be carrying some of that baggage forward, and I'll count myself in that group. You know, my attitudes on this have changed a lot in the last 5 or 6 years. And, you know, it took me a while to come this far. Part of building that relationship is reinforcing that chronic pain is real and there's a neurologic basis for it. You know, validate that patients have been in pain a long time and they want a quick fix. We're a quick fix society, right? You know, most of us communicate on a platform that only allows us 140 characters. Like, we want quick. So we need to level set and set realistic future expectations and not go for the quick fix, because any of us that have done this know that the quick fix doesn't exist. And then emphasize that this is a process where you're going to work together to get pain better over time. This is ongoing and it takes time, especially in somebody who's distrustful of the system. All right, so we've assessed, we build relationships. We know how to do that as palliative care providers. So non-pharmacologic and non-opioid therapies. So this is where, if we're not comfortable with what PT, massage, acupuncture, CBT, and exercise can do, this is where we need to educate ourselves or learn from our colleagues that are massage therapists or physical therapists, acupuncturists. You know, the data is not great. There's not a lot of robust studies in these for these things in the treatment of pain, but there's enough there that before going to opioids, they at least deserve the effort of seeing if they can be of some benefit on function. They should always be tried before prescribing opioids. And just keep in mind that opioids are never the first line therapy for chronic pain. So, you know, we don't know who's going to benefit from these. We don't know who's going to benefit from opioids, and the harms are real. So we owe it to our patients to exhaust all non-opioid therapies beforehand. And I just want to make a quick note on THC. This is a long lecture in and of itself, but there is some evidence for efficacy in chronic pain, particularly neuropathic pain. I would caution that in my experience with it in patients, it's not the magic bullet we all hope for, but there are certainly patients that benefit from it in this space. So let's just real quickly talk about opioids and chronic pain, because this is a huge topic and we can't go as deep as we need to. But there's 2 points that I want to make about opioid use in patients with chronic pain and serious illness. And the first is you have to apply a approach of universal precautions. And no matter what, this is always a risk-benefit calculation. So why we apply universal precautions is because we have tools that help us stratify risk and identify patients who are at higher risk. But what we don't have is a tool that can predict who's at low risk or no risk. So we have to assume everybody has risk. And then taking that risk to the second step, which is making this risk-benefit assessment in our head, and then deciding whether we're going to go forward with opioid therapy in this patient. So using universal precautions, it's the best strategy for detecting opioid use disorder, preventing opioid use disorder, controlling patients' pain, and overcoming bias. If we do the same thing over and over for each patient, regular visits, not letting people go 3 months in between visits, but seeing them regularly, using opioid treatment agreements, not just as a punitive fallback, but as an educational tool. That's, to me, the greatest use of opioid treatment agreements is an educational tool for our patients to help them understand what our approach is and why we're worried about harm just as much as we're worried about efficacy of the medication. Urine drug testing has its utilization. Prescription drug monitoring programs in I think almost all the states now, and then naloxone training as well. And I hyperlink to the SAMHSA site where you can get naloxone training. But if you do these things, I just want to make a point here that you will overcome implicit bias too. Apply the same thing, make it muscle memory. So every patient that comes in, you're applying this to. And in clinics that I've set up for outpatient palliative care, we do this with every single patient because we can't tell who's low risk. I'm sure all of us, if we've been practicing long enough, have the story of the 75-year-old grandmother who came in with her quilt on and her, I remember the one that opened my eyes. She had her tissue rolled up in her sleeve so she could dab her nose when she needed it, and then she put her tissue back in her sleeve. And I would have thought this is the last person in the world that would have had fentanyl patches on the bottom of her feet, but she did. So, there is a way around that, not stigmatizing people and not creating angst within ourselves about who has this, who doesn't. Apply the same format to everyone. So that's universal precautions. Weighing the risks and benefits, it's about, it's really about things that impact the risk-benefit equation. So if prognosis is short, you're going to take that into consideration. Someone with pancreatic cancer who has only a few weeks to live, you're going to weigh the benefits of opioid therapy much more strongly than you may weigh the risks of development of opioid use disorder or anything like that. Now, what about somebody who's expected to improve with disease treatment? Like, let's say it's somebody who's going to respond to radiation and we would think their pain may become less, or their illness may be curative. They're in palliative care, but their illness is curative. So where do we go with those patients if we start them on opioid therapy and they're maybe at high risk for opioid use disorder? So it really comes down to screening and monitoring. There's good validated tools to use this. The opioid risk tool is a common one. Greater risk really means closer monitoring. So you weigh the risks and benefits, and then you take the results from that to decide, A, if you're going to prescribe opioid, and B, how close are you going to monitor those patients. And so I don't know how well this shows up because this is a screenshot from one of our CAPC courses that we built in our pain curriculum. But it just gives an idea of how your level of surveillance really should increase with your suspicion or worry about somebody developing substance use or opioid use disorder. So, we use the ORT. There's other instruments. I know some people are pretty polarized on the ORT, but if you use this just as a guide to say, okay, you score high enough on the ORT that I'm a little bit more worried, you're going to do more frequent follow-ups. You're going to maybe consider, getting some input from your palliative care medicine consultants if you're in primary care, or maybe your addiction medicine consultants if you're in palliative care, and really just watch them more closely. The bottom line is we can't identify anybody who's low risk, so we have to apply universal precautions. And all patients need to have their pain managed. And it's just about weighing the risks and the benefits and adjusting your surveillance. So deprescribing, who do you deprescribe for? Individuals with poor function despite opioid therapy, individuals who are at high risk of opioid-related harms. These are the patients that maybe have a history of alcohol or even opioid use disorder in their past, who are on opioids now and aren't having the effect that you thought they would, or they're at high doses of opioid with not the effect you were hoping for. These are patients that you want to be considering deprescribing. And then obviously anybody experiencing opioid-related harms. The note I want to make on this is think voluntary, not mandatory. The CDC guidelines get very misinterpreted in that, there's this mandatory approach that we have to take, that we have to always be reducing people's dosing. I think the approach you need to take, especially if you're serious about building relationships, is to approach this as a voluntary thing. Hey, I'm worried about you. We've escalated the dose of your medicine to a point where, we're not seeing the results we wanted. Why don't we try, adding some non-opioid therapies and maybe bringing down the dose a little bit just for your safety, and do this in a conversational manner that's voluntary and not coming in and saying, I'm doing this because I have to. And then have a plan for opioid misuse. Don't immediately stop opioids if somebody has trouble. There are a million reasons for people to have problems with opioids. Classic example, somebody goes to the pharmacy doesn't have enough of the opioid in stock, they get a partial fill, they go back to the pharmacy to get the rest of their opioid, the insurance company won't cover it because they already had it filled once that month. Is that someone with an opioid use disorder? Probably not. Is that somebody who's misusing their opioid? Well, it sure looks like that on the surface. But if we were to immediately stop opioid in someone like that, we'd be doing them harm and a disservice because it really was out of their control. Which leads me to the next point, which is develop a differential diagnosis. Approach opioid misuse or aberrant behavior, or whatever terminology you want to use. Develop a differential diagnosis. Dig deeper. Find out what's happening. Is it a health literacy issue? Is it a pharmacy issue? Is it a side effect issue? Is it an OUD issue? You need to develop all those things in your differential. You have to determine if it's a pattern. Seeing one behavior in a snapshot is not helpful. You have to see patterns of behavior over time to really make a diagnosis of OUD or SUD. And at some point, you may have to make that determination. If there's a repeated pattern, if it's interfering with somebody's daily function and ability to do their work or have relationships, then you need to be comfortable with the DSM criteria for OUD and make the diagnosis. And then, most importantly, know how to intervene. So there's some great resources for handling misuse behaviors. My Top Care is a great website where it actually is a punch list of things you can do when you start finding the common things we see in practice, calls for early refills, taking meds in ways other than they were intended to, how to deal with inconsistent tox screens. All those things are kind of covered there. But I want to just take it one step further. Having a plan also means knowing what resources exist in your community and developing relationships with those folks to have smooth handoffs if you do run into trouble. And then if you don't have those resources in your community or they're very limited, you may want to consider buprenorphine training so that you can handle this yourself if it happens. So I know that's another big topic and I don't want to go too far down that road, but you need to have a plan for if you uncover what we all worry about uncovering. And if you have that plan, if you have those relationships, or you have your bup training and you're comfortable with its use, this takes a lot of that knot that you feel in your chest and your stomach out of it, is knowing that if all goes south and our worst fears come true, we know what to do. So just some quick takeaways. Palliative care and chronic pain intersect. I would argue that palliative care and OUD intersect too. And if we don't treat these patients when they develop serious illness, who will? It's difficult to predict risk for OUD, especially low risk. So we have to apply universal precautions. We weigh the risks and benefits, and we adjust our surveillance to the risk assessment. Building relationships is key, and we need to have a plan for things that go wrong. And the last thing I want to say, and I have typos on this and it's not finished because I was doing this right before I logged in, but this should say takeaways to, and my point was assessment. You know how to do this as palliative care clinicians. Build relationships. You know how to do that as palliative care clinicians. Using non-opioid therapies, you probably all know how to do that. There may be some that you're less comfortable with than others, but you certainly can learn them. You know how to do it. Opioid therapy, what to do if non-opioid therapies are effective and you are going to use opioids. We know how to do opioid trials. We know how to manage pain in seriously ill patients. It's no different. It's just about applying universal precautions, doing your surveillance at a level that makes sense, knowing how to deprescribe if you're not seeing functional improvement in a patient who's on opioids or somebody who's having trouble. And then you also need to have a plan. So we may not be as comfortable with deprescribing or having a plan, but if you invest a little time in those, I think you'll find they're not super intimidating. They're not that scary when you do your BUP training or if you start building relationships with your addiction medicine colleagues. And these are the things that maybe they're not what we're comfortable, that we don't know how to do already, but we certainly can learn. And if we're serious about taking care of, making sure palliative care is available for everyone everywhere, part of everyone is patients with chronic pain or opioid use disorder as well. So with that, I'll wrap it and we can just go into this to discussion if that's okay with you, Martin.
Wonderful. Thank you, Andy. There are a lot of comments in the chat section. Rather than reading some of them, how about we just open it up for discussion? If anybody wants to unmute, talk, and ask a question or make a comment.
Jump in. I want to, as I said in the chat, thanks, Dr. Esch, for talking about this because it's much needed discussion. And as you said, it's very polarizing. So I kind of have an involved question. I don't want to dominate the time, but I know firsthand the balancing. When I was in charge of implementing a palliative care program in a rural setting several years ago, we took the approach that we would not rule out chronic pain, but probably things we should have seen, the chronic pain basically swallowed up the palliative care program. And so with a different iteration of that, we've kind of gone to that other pole. We say, and I agree with you again, but we say, yep, chronic pain isn't part of our patient volume. So do you have any suggestions on where we're at now to kind of not so much ease into it, but how do you balance that so that it doesn't become the identity? And the reason I think rural is important is because both patients that had chronic pain and the primary care referral providers, they were so willing to not be dealing with these patients, quite frankly, that's part of why we got swallowed up.
Yeah, that's a great point. And so we can't solve the chronic pain problem. Like this is beyond our capacity to do it. We're under resourced to do what we're already being asked to do as it is. So to take that on it can't be part of what we do, but we can be part of a solution with our other subspecialties and colleagues. And so my advice to programs that ask questions like this is I use it as a negotiating tool. I go to if the health system, before COVID hit, probably one of the biggest things on health systems' mind was what do we do with this huge population of chronic pain and OUD patients that we have that are accessing our ERs, that are in our primary care clinics, and how do we address those? Well, in palliative care, we can't own the whole solution, but we can own part of it. If they have coexisting CHF, COPD, other things we're managing, those patients we can incorporate into our practices and manage their pain. What we can't do is incorporate the construction worker who fell off a ladder 23 years ago and has been on hydrocodone for 23 years and now is having trouble. Like we do need to partner with addiction medicine and other areas within the health system to be part of a more global solution. So what I would, my short summary of that is I use it as a negotiation for my program. Hey, we know this is a problem. We would like to be part of the solution, but to do it, we're going to need more resources and we're going to need to partner with some other people to become very clear on who's right for us and who's right for others. Because if you open your doors to become the chronic pain practice, it's over. You'll have great RVUs. You'll see tons of patients, but that's not really what we're set up to do. I hope that answered the question or addressed it.
Yes, thank you.
One comment I've got is that I think one of my biggest fears, and it has to do with education, is just being prepared to address some of the new comorbidities that might come along with chronic pain. There was a review article maybe 10 years ago, I think it was by Bob Arnold, Dr. Merlin, a few others, that talked about palliative care needing to be prepared to face these new comorbidities. And I think the example they gave was personality disorder, and how in some chronic pain populations, it can be anywhere from 40 to 60% in some of these studies. And that feels daunting. That's a new skill set to be learned that I didn't feel like I got to see enough in fellowship to be prepared for.
Yeah, there's a lot of complexity in this patient population for sure. And that's why, the message really needs to be to whatever system you're working within, is that we are willing to step up and be part of the solution, but we need psychiatry to step up, addiction medicine to step up. We need partnerships with these folks to be able to truly address. And this goes even beyond, there's community resources, food insecurity, people that are homeless, like these things impact their ability to comply with treatment, make appointments, things like that. So it really has to be a community effort with the hospital or outpatient clinics as part of that community addressing it. So again, the key word here is negotiation. Like I'm not saying, hey, palliative care teams, go in, open your doors to all comers and be the solution. I'm saying offer to be part of a solution and use that as a negotiating tool to get the resources that you need and the partnerships that you need to develop to be able to be part of a more global solution. So it's interesting you bring Jessie up, because a lot of this content, we're building a curriculum on this with her as the main author.
Oh.
A lot of this content is from those slides. So Jessie's who have presented with this in the past. So, she's really passionate about this, but I think when you dig deep into what she's actually saying, she will say, we can't be the whole solution.
Gotcha.
Right. It's really good topic. We have a cancer clinic here, and as we talked, some of the patients that we are seeing would have opioid use disorder. They really have cancer pain, true cancer pain, for which they are receiving opiates. But at the same time, some of these patients have used substance all their lives, so they are doing cocaine. And we have a team here, a multidisciplinary team. We do all the universal screenings and have more support staff. We have counselors, we would have social work, we would have nurse practitioners and doctors, and we are providing them support and counseling and digging into their psychosocial distress and providing all the support that we need to address all the concerns, right? But again, that's where I feel like, burnout comes, because, when you have a lot of these patients and you are trying to do your best to keep them safe, at the same time, control their pain, and you are still, sometimes you're seeing that despite of all of your efforts, there is still ongoing use. And we have tried sending them to addiction medicine, to chronic pain management, to see if there is any intervention that can be used, or non-opioid therapies. But usually the patients are resistant. And again, we look at the prognosis too. It depends, if the prognosis is shorter, we understand we are trying to minimize the harm and controlling pain to the best efforts. But then we also have some patients who have prognosis of 10 to 15 years. And it's hard to say if the pain is just coming from cancer, or it is just the history of chronic pain and the opioid use disorder or the substance use disorder is playing part, right? And for that, we have a big team. But at the same time, when you have a lot of this patient, you feel like, okay, you don't have enough resources and time to manage all these patients. And that is something that we are observing here.
Yeah, and I think that's pretty universal, and that's the challenge. I'll take two quick answers to that. One is, one of the ways to get around the, it may be more the opioid use disorder and not the pain that's driving the behavior, is to really look at functional assessment above all else. So if you can If you have a patient who's constantly coming in saying, I feel worse, I feel worse, I feel worse, this is part of building a relationship. You sit down and you say, we've tried this, this, and this, and every time you're not feeling better, maybe this isn't the answer. We need to deprescribe and think about some other approaches. How do you feel about that? And make it, make it so that you're still worried about them as a person. You're not using accusatory language, but you're focusing on the only objective data that you really can, which is their functional status, right?
Mm-hmm.
Subjective, we used to say if patient says they have pain, they don't. That's how we got it, or they do. That's how we got into trouble. When we look at functional assessment, I think we can apply some more of our scientific training to what we're doing. The other thing is, I absolutely agree with you. We don't have enough resources to do our current workload. How do we do this? This is where the negotiation comes in. Because trust me, this is keeping your health system administrators up at night too. They know this is a problem that's costing their hospitals and health systems a lot of money and a lot of resources. So, going in saying, I'd like to be part of helping this problem, and this is what I think we can do, but we're going to need some more social work. We're going to need, maybe a few more nurses that can really do the tracking of some of this surveillance. Not all this has to be prescriber. A lot of this tracking and support can be from other people in the office. But I'll tell you, it's getting harder and harder in medicine today to get somebody hired who doesn't generate RVUs and revenue. And that's a tough space to be, but this gives you an argument to maybe do that.
Thank you.
Yeah.
All right. Well, thank you, Andy. I really appreciate your time today. I know we've kept you just a little bit long, but
okay. I'm happy to be here. Thanks, Martin. Thanks, everyone.
Absolutely. Have a wonderful weekend, everybody. See you later.
Bye.
Bye.